It's U of L Today on 93.9 The Ville. Here's your host, Mark Hebert.
And welcome to U of L Today with Mark Hebert on 93.9 The Ville. As many of you know who listen to this is the show that tries to show the breadth and the depth of everything going on at the University of Louisville. We have 6,000 employees, 23,000 students. So this program lets you hear from the great students, faculty, staff, and researchers at U of L and all the great things they're working on, many of which have an impact on each of our lives. So one of those people that's made an impact on a lot of lives is Dr. Ron Paul. He's a U of L doctor who for 25 years worked in the emergency room at what was known then as Kosare Children's Hospital. We'll talk with him about caring for children and the changes he's seen in pediatrics over the years. But first, a lot of people cast their vote for president based on who their candidate was likely to nominate to the open seat on the U.S. Supreme Court. And would it be a conservative or a liberal judge? Well, with Donald Trump in the White House, we now know the answer to that question. Laura Moyer is a political science professor at U of L who's been looking at how President Trump might influence the federal court system with his nominations and what it means for the future of the United States of America. Welcome, Laura.
Thank you. Glad to be here.
I saw a presentation you did. That's probably been a month or so ago. It was right after Donald Trump was inaugurated. And in it, you had some startling numbers about the number of vacancies and the impact that Donald Trump could have on the Supreme Court. So I want to talk about that at some point here. But first, let's talk about what people are really staring right in the face right now, the Supreme Court nomination. We've got a Supreme Court nominee, and President Trump has made, obviously, picked a conservative judge in Neil Gorsuch. What are the chances, A, that Neil Gorsuch will be affirmed, and then we'll go from there.
Sure. So one of the things that's very striking about Judge Gorsuch is that he looks very similar to what we would have expected a President Rubio, a President Kasich, a President Cruz to nominate to the Supreme Court. I mean, he's a very conservative judge, but he's also very well qualified. And given that the Senate is held by the Republican Party, and given that he's very well qualified, and also that public opinion on him is thus far pretty positive. It's more positive than it is towards the president. That all those things suggest that he's very likely to be confirmed. Of the Democrats who are ideologically close to Judge Gorsuch, I believe 10 of the 12 of those are up for re-election in 2018, some of them coming from conservative states, others coming from swing states. And when you have a judge who's very well qualified and who is ideologically not that distant from a senator, the likelihood that the senator will vote yes is actually quite high. So I would say that Judge Gorsuch has a better shot than Merrick Garland did.
Yeah, well, he had zero shot
That's
since
right.
Mitch McConnell wasn't going to bring up his nomination. So for Judge Gorsuch, I mean, he's got to get, right now, 60 votes.
That's right.
In the Senate. Do you think that the Republicans will have to blow up that 60 vote majority and go back to what used to be the old rules and just have a simple majority, or will they be able to get 60 votes and get some Democrats, 8 to 9 Democrats to go and vote for him?
Well, this is a very interesting area because the current state of the confirmation process is for lower federal court appointments. There is no filibuster, and so those just require a simple majority. And that was part of the nuclear option that was worked out when Harry Reid was Senate Majority Leader, and the Democrats held the Senate. There is, I think, a lot of concern on the part of both Republicans and Democrats that if you take away the filibuster altogether, you hamstring your party when your party is no longer in the majority. The Senate is quite close right now. And so there is already at least one Democrat who said that they will filibuster the nomination. But given the electoral prospects for many of the other Democrats, I suspect that they will be able to get cloture. So I think that even with the prospect of a filibuster, I think that Gorsuch is pretty likely to be confirmed, but that this will come at a cost to the president. One of the really interesting things that we've seen is that the more a president pushes a nominee, so the more public statements they make about a nominee, the less successful other aspects of their policy agenda are. It actually goes down quite a bit for every public statement a president makes on behalf of them.
Because they spend too much political capital on their Supreme Court nominee?
That's right. That's
Okay.
right. And the president right now is sitting at a pretty unusual position for a first-term president. His favorability ratings overall are quite low. They're very high among Republicans. They're incredibly low among Democrats. And going back, at least through Carter, this is really sort of unprecedented.
I think one thing you pointed out, and others have pointed out as well, that having Neil Gorsuch as the new Supreme Court justice, assuming he's confirmed, the court's basically going to be the same as it was when Scalia was alive, and you had 9 justices on the court, right?
That's right. That's right. I mean, analyses kind of differ. I've seen where Gorsuch would be basically where Alito is now, but certainly he's going to be on the more conservative end of the court. And so you'll be, back where Kennedy sort of remains to be the swing vote. Justice Kennedy is more libertarian. He's kind of gone both ways on abortion. He tends not to be incredibly liberal on issues relating to race, but on gay rights, Kennedy has sided with the liberals consistently. So really, this battle is not the big battle for the Supreme Court.
It's the next one.
It's the next one and the next one and the next one, because
Right.
we have 3 justices who are approaching at or past 80 years old.
So Donald Trump will have what kind of potential impact just on the Supreme Court, assuming at least one more judge resigns or retires?
So the oldest justice on the court right now is Justice Ginsburg, and she is, one of the leaders of the liberal wing of the court. She's not the most liberal justice on the court, but appointing a conservative justice in the mold of Judge Gorsuch would change the court markedly in cases involving race, involving voting rights, involving the death penalty, involving many other issues that people care a lot about.
We're talking with Laura Moyer from the University of Louisville. She's a political science professor, and we're talking about the courts and Donald Trump. So I asked the question before the break, what impact might the current federal courts and the makeup of the current federal courts, particularly in Washington, D.C. circuit, have on these executive orders and the lawsuits regarding these executive orders that Donald Trump has issued?
Well, I think one of the things to remember about the judiciary is that when a president's appointing judges, those judges are there for life tenure, and so they sit there to evaluate the actions of Congress and future presidents. And President Obama has been very successful in transforming the lower federal courts and in courts like the D.C. Circuit Court, which is sort of viewed as a stepping stone to the Supreme Court. That appeals court will hear challenges to regulations that come up through the federal agencies. For example, changes to EPA regulations. They hear the enemy combatant cases. And so the chief judge of the D.C. Circuit is a judge you may have heard of, Merrick Garland, whose nomination was not considered by the Senate. And so Donald Trump will be making, and the Department of Justice will be making arguments before many judges who were appointed by President Obama.
And one that President Obama tried to appoint to the Supreme Court, but didn't even get a nod,
That's
right?
right. That's right.
So, I mean, from your perspective, if you're in Merrick Garland's shoes and you're hearing a case that Donald Trump is trying to defend one of his executive orders, is that likely to trickle into your thinking and to your reaction to having Republicans in front of you and a Republican lawyers and a Republican president in front of you that just said, sorry, we're not even going to consider you for the Supreme Court?
I mean, I think from what everyone has said about Merrick Garland is that he handled the situation with about as much grace as you could expect. But others around him were very upset, including others on the court, were upset with how he was treated. And so it may not be from him, but it might be from his colleagues who have a little bit of a grudge there.
I gotcha.
And you can even look at the Ninth Circuit with the challenge to the travel ban. One of the female judge on that panel was an Obama appointee. The district court judge in Brooklyn, who was one of the first to hear a challenge to the travel ban, she was also an Obama appointee. And, we know that makes a difference.
We're talking with Laura Moyer from the University of Louisville Political Science Department. We're talking about the courts and President Trump. One big issue that I was just stunned by that you brought up in your presentation a couple of weeks ago was the number of vacancies on the district and circuit appellate level in the federal court system. So why don't you go through those numbers and maybe talk about that a little bit?
Sure. So there's a lot of attention to the Supreme Court nomination right now, which is understandable because that's important. But President Trump inherited 114 vacancies on all other federal courts, including the U.S. Courts of Appeals, which are the court of last resort for most people who end up in the federal system, and also the U.S. district courts. And for comparison, Obama, when he took office, he inherited 53 vacancies.
So half.
George W. Bush in 2000 had 80 vacancies. So the president now has a lot of opportunity to make a very large impact on the lower federal courts and to really establish his legacy for things that he's able to push through Congress, his executive orders going forward. So this is a big opportunity for the president.
Isn't that, in your mind, bigger than one Supreme Court nominee? That in terms of the future, in terms of the future direction of the country and what the legal precedent will be years from now?
I think so. I mean, I think you could argue that would definitely affects more people in their regular lives. The other thing, though, is that these lower court nominations work a bit differently than the Supreme Court nomination, and that is that when you have a vacancy, so for example, here in Louisville, we're in the Sixth Circuit, and when there's a vacancy, as we do have in the Sixth Circuit, that vacancy belongs to a state, and both of the home state senators from that vacancy get to weigh in on who that person to fill that seat would be. And so this will be interesting to see how the president works in conjunction with states that have two Democratic senators, like in New York, where there's several vacancies, or California, or other places.
Right. In the Sixth Circuit Court of Appeals, is it just one vacancy?
Yes, just one vacancy. It's Judge Boyce Martin.
Okay, he just retired, and the Sixth Circuit oversees Kentucky, Tennessee, Ohio, Michigan.
Yes,
Am I right?
That's right.
That's not right.
That's right. It sits in Cincinnati.
From my reporting days,
Yes.
I remember that. I don't know why. So, what's the big deal about that particular seat and any other vacancies that would come up on the Sixth Circuit Court of Appeals in terms of folks in Kentucky and the lawsuits they take to federal courts? Why is it a big deal on who gets appointed to those judgeships?
Well, I mean, it's important for a lot of reasons. Obviously, these people have life tenure. In Kentucky, the vacancy actually sat open for longer than it might have because the president's people and Senator Paul and Senator McConnell were not able to come up with a suitable replacement that they could all agree on. If you can imagine what that Venn diagram looks like.
Yeah, with Obama trying to agree with Mitch McConnell on a judge, I don't think so.
And but what this means is that it also affects the partisan balance of each of those courts. So if you look at where which courts have majority Democratic or have Democratic majorities and which ones have Republicans, when Obama took office, he only 2 of the 12 circuits had Democratic majorities, and when he left, there were 8 majorities. So he was really able to have a large, lasting impact on the composition of the courts. But that being said, we now have the remnants of the Carter judges who are looking to retire. Some of them are dying. You have Clinton judges who may be looking to retire. And so even though we have 114 vacancies now, that's going to grow. And you may have more of the George W. Bush judges retiring because they'll be confident they'll be replaced by a Republican. So this will affect, as there are lawsuits to the president's actions across the country in many different circuits, this will affect how these things move up the chain.
So in a nutshell, what would you say to folks about the influence of Donald Trump's administration on the courts in the coming years?
I think that one of the things that's been very surprising about President Trump and the courts is that his other appointments have been very unconventional, but his approach to the judiciary has followed very standard, established Republican practices. So it remains to be seen whether he will follow that for subsequent appointments to the Supreme Court and to lower federal courts as well.
And maybe he won't be tweeting personal messages to some of these judges as well.
This is true. I mean, this is the judge, the lower court judge in the Ninth Circuit, Judge Robar, has gotten death threats as a result of some of this. So it's a very contentious environment to be a judge these days.
Well, I suppose before I let you go, I ought to ask you, do you think that will have an impact on how other federal judges might look at cases that come through and that are against the Trump administration when they say, hey, my colleague over here, Donald Trump's giving him hell on Twitter, either A, I don't want that to happen to me, so I might slide a little bit towards the Trump side of things, or B, I'm really ticked off about that. You know what? I don't like these guys coming into my courtroom.
I mean, I suspect that someone like Chief Justice Roberts, who oversees all the federal judiciary in his administrative role, is very upset by this because it's hard to get good people to be judges because it doesn't pay as well as private practice. So why would you choose to accept a nomination if you know it's going to bring lower pay and then the potential threats and public attention that you might not be looking for.
You think he'll tell President Trump to knock it off? Does Roberts have the guts to do that?
I don't think Roberts would invite a direct comparison, but when the Chief Justice they give kind of a speech about the state of the judiciary every year, I would not be surprised to see judicial independence mentioned, because we've seen this in the past with justices like O'Connor and others who've mentioned that they were concerned about this.
All right, Laura Moore, appreciate it. Thanks for being on the show. Appreciate it. He's the former chief of the emergency room at what used to be called Corsair Children's Hospital. It's now Norton Children's Hospital. Dr. Ron Paul held that post for 25 years before moving into his new and current job, which has a big fancy title, Vice Dean for Faculty Affairs and Advancement in the UofL School of Medicine. I decided I wanted to talk to him about the dramatic changes he's seen in children's medicine over those 25 years in the ER, and I guess he can talk a little bit about his fancy new title, right, Ron?
We can talk about the emergency department probably better.
Ron and I have been friends for over 20 years. I guess we ought to tell the audience that, so we know each other quite well. Well, let's talk about your 25 years in the ER. What was your job when I guess it was the old Norton Children's Hospital, Corsair Children's Hospital?
Corsair Children's Hospital first came. It was in 1991. I was recruited here. I was working in Cincinnati Children's Hospital in the emergency department there for about 2.5 years after I finished my training. And Larry Cook, who was the chair of pediatrics at the time, recruited me to come down and kind of develop the pediatric emergency medicine program here in Louisville.
Okay. So, but you are a U of L grad, right?
Graduated from UofL School of Medicine and did a lot of my other clinical training in Chicago.
Okay, so you went from when did you graduate from U of L, the School of Medicine?
School of Medicine in 1983.
Had to think about that for a minute. 83. Yeah. So, and then you went to Chicago, then to Cincinnati, then to Louisville, and,
right.
and you stuck around for 25 years as the chief of the ER, right?
Correct.
What'd you see in the ER? Tell me some of the stories there, Dr. Paul.
Lots of stories, but when I first came, the emergency department saw about 35,000 patients per year. Currently, the downtown emergency department sees 60,000 patients per year, wow. And our East End facility sees about 25,000 patients per year. So growth in volume has been tremendous. We had 5 pediatricians that were on staff at the time working in the emergency department. Nobody had really been formally trained in pediatric emergency medicine. It was a new specialty that really just developed in the 1980s. Has now grown exponentially since that time. And so in the last 25 years, it's just been tremendous growth. And right now, there are about 21 pediatric emergency medicine trained faculty that work in the 2 pediatric emergency departments, the Norton Children's Medical Center and the Norton Children's Hospital downtown. And we also have a fellowship program, a training program for 9 fellows, 3 fellows per year that are in training for a 3-year program. We have 12 nurse practitioners that work with us side by side, seeing patients with us. And so it's just a tremendous amount of growth in that time.
And the majority of those doctors are University of Louisville doctors, correct?
I'd say about a half to 2/3 of them are U of L trained doctors, either went to medical school here or did their clinical training in pediatric emergency medicine here with us.
Gotcha. And you said, I think I added that up correctly, 60,000 at one facility, 25,000 at the other per year, so that's 85,000 visits in the emergency room at one of the children's hospitals. I can't divide that out. How many is that per day? I'm not a mathematician.
It's a lot.
So that's a lot of kids walking to the emergency room with their parents every day. So what's the big change you just mentioned was the number of children that are walking into the emergency room and also the number of doctors that are on staff. But what are some of the other things, the changes in medicine that you've seen over that time?
It's really been, I look back, it's been such a tremendous amount of changes. I mean, I'd say the biggest area of change would probably be in pain and sedation, how we treat patients, the pediatric patients that come in that have injuries, would be lacerations or fractures, and the types of medications that we give them now and the way we treat these injuries to try to make it as pain-free as possible.
Well, I noticed in a story that Maggie Roker did, she's one of the PR people for Norton Hospital, she said that a solution of cocaine was used as a local anesthetic to repair cuts way back when, 25 years ago. Are we still using cocaine in the emergency room?
No, we stopped that in the probably mid to late 1990s. But for the first few years in the 90s, it was the common drug used. It was a solution made out of tetracaine, adrenaline, and cocaine. Cocaine is actually a very strong local anesthetic, so it causes pain relief, and it's also a vasoconstrictor, so it slows down the bleeding. And it was a solution that we would apply to cuts, and it would be just local anesthesia around the wound, and it would really work great. It was safe to use unless it dripped into areas where it shouldn't be, like the mucous membranes in the mouth, around the eyes, and then it could potentially cause some serious problems. but it was also expensive because of the cocaine. I mean, and so in the mid to late 1990s, we changed to another solution that became popular. Was just has lidocaine, epinephrine, tetracaine. It eliminates the cocaine part. I think back today, and I think if I was working in the emergency department today and was coming to a family who had a little cut on their child's face and said, we're going to put some cocaine on the wound, I think I'd probably get a lot of stares.
You think you might get some pushback on that?
Yeah.
Well, you could just give them a Coca-Cola back in the day, back in the 70s, because Coke was using cocaine at the time.
This was actually pure cocaine mixed into a solution, but it actually did work very well. But it's just one example of how far we've come from the early 90s. And other things, we used to repair fractures. Children that had bone fractures that were angulated that needed to be set straight. We would give them a shot of a pain medication called Demerol, Phenergan, and Thorazine, and it would work well because it had Demerol in it, but it was not consistent. So some patients would get good pain relief, and other patients would still be kind of emotional or crying and in pain during their fracture reduction. And now we routinely put an IV into place, and we give them small doses of an anesthesia medicine called ketamine. That works great. And so the patients go to sleep, they have no pain, they have no memory of the reduction, and they wake up and an hour later and they do great. So it's such a much better procedure. In addition, we have a group of child life therapists that use distraction techniques for children, so that when we're repairing wounds, we used to use a lot of restraints. We put them in a papoose board and strap them in, or we wrap them in a sheet
so they
like a
couldn't flail
mummy.
around and
couldn't
stuff.
flail around, and they cry through the procedure. And now we may give them a little bit of an oral sedative medication, and then we use our child life therapists that entertain them with books or movies. They hold up iPads with movies and different games that they play with them based on the child's age. And you can do all these procedures in these children that you couldn't used to do without restraints back 20 years ago.
We're talking with Dr. Ron Paul, who's a pediatrician. Now he works in the dean's office at the UofL School of Medicine, but for 25 years he was the head of the PR department. No, you weren't the head of the PR department. You're the head of the ER department at Kosair Children's Hospital here in Louisville. Some of the other things I think that were really interesting was the difference in what you do with parents when they walk into the emergency room. Nowadays, doesn't the parent just hang out with the kid the whole time?
Yeah, it's far different. Again, when I first started in the field, it was routine that parents weren't allowed during procedures. Anywhere from just placing in IVs to lacerations to lumbar punctures to even full resuscitations. You'd immediately take them out of the room, and you'd put the child in a different room, and you do the procedure with the nursing staff. And then you bring the child back to the family, and the family would be sitting there in an isolated room just wondering, scared to death about what's going on with their child. Now it's routine. The parents stay in the room for all procedures, and I'm talking about lacerations, lumbar punctures, placement of IVs, and even full resuscitations. When we have a child come in who's undergoing, CPR, or after a bad trauma incident, we have a trained staff member that will stay with the family in the back of the room to explain to them what's going on while we're doing the full resuscitation of the child. And actually, it's much better. Some families don't like it, and so they step out of the room, and that's fine. But many families want to be there when their child's undergoing these procedures.
But as a doctor, you think that's a good thing that's happened?
It's a very good thing. It really is. It gives families the knowledge that you're doing everything you can for their child, and they leave the department knowing what happened to their child. And if it's lumbar puncture, a lot of times they're sitting next to the child's face, actually helping the child get through the procedure as well.
Is it the majority of children that come in, is it for breaks and bones and bruises and stuff like that? Or is it now, has that changed dramatically as well? Do you have more kids coming in with more complicated illnesses and injuries, or who's walking into the emergency room?
So it's all sorts. I mean, we have families come in with children that have acute rise in their child's fever late at night. Their physician isn't available, and they come in to us because they're scared that their child has a significant illness. Sometimes they do. More often, it's a simple infection that we can treat adequately with either over-the-counter medications or antibiotics. We also have injuries that, simple cuts. The kids fall into the wall and cut their forehead, or they fall off their bike. But then you have a significant number of patients coming with very serious illnesses, meningitis, pneumonias that need, significant amount of resuscitation, admission to the hospital. And the growth and the complexity of the care of patients has really been tremendous. And that's because the overall growth in medical care. We have patients now that didn't used to survive their illnesses, whether it was from extreme prematurity or from cancer or very, very bad congenital heart disease. and now they're home and they're thriving. But when they have acute problems, they need to come into the hospital, and sometimes they're always kind of ride the fence a little bit, where they do okay, but yet a simple illness, a simple cold can set them off that fence, and then they need to come in with a significant medical problem. So the complexity of care is tremendous. Patients, we have patients that come in that we do in the emergency department. They come in with severe pneumonia, for example, and they're in severe respiratory distress, can't oxygenate, and even nothing that we can do can save them except putting them on ECMO. ECMO is kind of cardiac bypass. In the 90s, it was only used really for maybe adults that were getting cardiac bypass for placement of, for a bad heart attack or an occlusion of one of their cardiac vessels. Now, occasionally, we actually do this in the emergency department with our ECMO team that comes down and can really save a child's life.
So the advances in medicine, bottom line, have meant children living longer, but when they walk into the emergency room, they may have more complicated problems because they may have what used to be a disease or something that would have caused them to die years ago.
That's right.
Now they're living.
Yeah, they live longer, they live a full life, but they have medical problems that can have acute issues that need to be resuscitated.
On the downside, and we're talking again to Dr. Ron Paul from the University of Louisville. He's a pediatrician and also now works in the dean's office at the UofL School of Medicine. On the downside, you're seeing more cases of sexual and child abuse, correct?
Yeah, physical and sexual abuse is certainly been on the rise for many years. And unfortunately, Kentucky is, for many years, has been one of the leading states in the nation in terms of child physical abuse and sexual abuse cases. We used to actually lead the nation. We're probably in the top 5 or top 10, but we're not leading the nation anymore. But it certainly has been a rise, and it's I think it's a sign of just it's probably two things. One is we're recognizing it more, and so therefore we're treating it and finding it earlier, and more physicians are aware of it and sending patients into us to be evaluated. The second thing that there probably just is an increased number of cases with just the social ills that are out there in society.
Yeah, but the reporting, I think, has gotten so much better over the last 25 years.
Absolutely.
That certainly has jumped the number up, I would think, correct?
Yes, it has. And we have more sophisticated testing, and we actually have specialists called forensic medicine specialists that help us in the hospital that do help us with the thorough evaluations and recommendations for the care of these patients.
Are the kids who are walking into or getting carried into the emergency room, are they going through less testing? Do you have better ways to figure out what's causing a problem, or are there less concerns about malpractice and those kinds of things that you're just doing less tests?
I think we still have concerns about malpractice, especially in our state where there's been a lack of malpractice reform. But yes, we probably have more research and better research that allows us to do less testing. For example, CAT scans for routine, head injuries. A child would fall, hit their head, maybe have a cut, maybe pass out for a few seconds, or have one episode of vomiting. In the past, it would be routine. They'd come in and get a CT scan of their head to make sure there wasn't a significant injury. And now we have better research that really helps tell us whether that child needs a CAT scan or not. And a CAT scan is not a simple test. It's a significant amount of radiation exposure to the child's growing brain. So you want to do it when it's necessary, but you don't want to do it when it's unnecessary. So we're actually probably doing less blood counts, less CAT scans, less invasive tests than we used to do. On the other hand, we have better technology that allows us to do tests to come in with the same diagnosis. For example, the diagnosis of appendicitis used to routinely be made with a CAT scan of the abdomen. Now we routinely use ultrasound because we have skilled radiologists and skilled ultrasound techs that can help detect the appendix if it's enlarged and inflamed, and avoid in many cases getting a CAT scan of the child's belly.
All right, so to wrap up, what would you tell parents about the overall, the difference of what they're going to see when they walk into an emergency room at Children's Hospital nowadays in Louisville, Kentucky versus 25 years ago?
Well, they're going to see more trained specialists in pediatric emergency medicine, a more concerted, coordinated team of approach with nurses and child life therapists and respiratory therapists and pediatric emergency medicine trained physicians to take care of their child. And they're going to, I think, find a better overall patient experience.
Thank you for listening, and go Cards.